I'd like to thank Greg Alexander and the American Academy of Pediatrics for allowing me to talk to you a little bit about healthcare quality and healthcare IT and how hopefully we're going to stitch a lot of this together over the next several years. If you go to my first slide, it talks a little bit about care delivery trends. And what we've seen in medicine is the fact that forever we've been paid for doing services in our offices. That's about to change. We're about to migrate over to being more a patient-centered medical home, a bunch of caregivers together, working together for the health of their patient population. And if that's going to translate over into, if you look at health payment trends on the next slide, going from payment for services, which we're paid for today, into payment for outcomes. And this is a very, very clear direction that the federal government is taking, as well as a lot of private payers. So we're going to have to demonstrate our quality in some shape or fashion. And the bulk of what I'm about to tell you, I think, is based on how you're going to do that in the technologic world and given all of what we have to do in medicine today. So looking at healthcare IT, when you look at the trends there, when EMRs first started, they were data capture. So was ours at MED3000. That's what we did. We collect data and we collect it very, very well. But what we're transitioning into is measuring outcomes and allowing patient populations to come together and be monitored and sliced and diced in a way that you can actually start to target care. What we've done with our data warehouse is actually layered upon the top of it something called a predictive modeling engine, which will allow you to say, of these 100 patients that have diabetes, what are the 5 of those patients most likely to need care over the next year? And be able to start to target that care, both from a physician level, an extender level, as well as the patient education level. So who do you target care? Because you're not going to have enough time, money, or effort to treat everybody the same. You're going to have to start to focus a little bit, and healthcare IT can actually start to help you do that. So, if you look at the next slide, why an EHR? What's an EHR going to give us? Every time I talk to a physician, one of my colleagues, they say, this slows me down, I don't like it, it's a mess, why would I ever have one of these things in my office? I can document faster on paper than I can anywhere else. So, what does an EHR give you? Well, it gives you timely access to healthcare, accurate data, and this is anytime, anywhere. When you're at home, sometimes you don't have access to that patient's chart. Sorting of that information, like I talked about with population health management, how do you get to that one piece of information you need at 2 o'clock in the morning that's going to make or break the decision you're going to make for a particular patient? EMRs do that very, very well. Patient-specific data, how do I know exactly what this patient's had? In a chart, if you look at some charts, at least in my office, they were fairly thick, so trying to sift through all that information quickly was kind of hard to do. So now I can start to cone down on very specific pieces of data, plus access to knowledge-based tools, clinical decision support tools, which are getting better and better as time has evolved here in technology, to allow physicians to be presented with what they need to know at the point of care. I'll digress just a little bit and say when I first started in healthcare technology 15 years ago now, I didn't know the word genomics other than the fact I learned it in medical school, and there are genes that dictate what we have. Now there are over 550 different genomic-specific tests out there that physicians are going to have to be aware of because they start to direct care. They start to predict what a particular patient's going to have. And how you keep up with that, I really don't know unless you have an electronic way to do that in some kind of database. Information delivered right at the point of care when you need it, as well as being able to manage multiple patients. One of the things that's going to happen over the next several years is this concept of health information exchanges is actually going to take off. There are 15 states right now that have their own information exchanges up and running. Now, they're not robust yet, but they're running. And other states are starting to get that grant money from the federal government and set these up. So now we're going to start to be able to communicate between physician to physician, specialist to primary care, and do that on a real-time basis. Next slide talks a little bit about tracking cost and value. One of the things that we're going to have to do as physicians is demonstrate our cost and our quality and our value. And I'll talk a little bit about quality here in just a minute, but that's going to be we have to be able to demonstrate that we do care at a specific level that's reasonable given other people's eyes. So what I think quality is may not be what other people think quality is, and we're going to be measured. The federal government over the next 5 years is going to make it very, very clear to all of us that it's transparent. So report cards are going to be on the internet for people to look up and see what Dr. J. Anders did for his particular patient population as opposed to Dr. Smith and Dr. Jones. So assessing provider performance, information for research. EMRs are wonderful for doing patient mining and data mining. They do that extremely well. Communicating across distances. If you're in an enterprise right now, a multi-specialty group practice, you have the ability to communicate across that group practice probably if you're on an electronic system because you're on the same system. We're about to take that to the next level because all the systems that have been certified since 2008 have to meet a certain standard for communication. So now we're going to be able to start to give information to other systems via something called a CCD or CCR that will allow that to start to happen. So if I wind up in the emergency room in California, they're going to know what J. Anders has because my medical record will be available to them. Monitoring of patients remotely, that's going to be also something that's connected to the patient-centered medical home that I talked about in that care team. A lot of the vendors you see here are producing items that will connect via the internet to devices that will transmit that data to an EMR or to a doctor's office. So now I'll be able to sit there and monitor all my diabetic patients in my office because that data is coming in as they start to check their blood sugars. So now it starts to be real time, and I can have my EMR set up to an alert that I can say, okay, for certain patients, their blood sugar came in at 350. I need to get a hold of that patient because now not only are they accountable for their care, but I'm accountable as well as far as that quality is concerned. So let's talk a little bit about what is quality. Now, when I talk to physicians across the country, what they tell me is, I know what quality is, I deliver it. We're kind of that way. But quality, actually I borrowed this from the University of Michigan on this particular slide. Quality needs to be patient-centered. What we're after is, in medicine, we're focused on our patients. We want to make them better. So it has to be responsive to their needs, preferences, and values. It also has to be effective. One of the things that is starting to really take hold in medicine across the country, all specialties, is something evidence-based medicine. You hear that a lot. Out there for any particular disease, any particular situation, there is a best practice out there. There are certain things you should do when you have a certain particular condition that's going to give you the best outcome over time. Now, you have to tailor it as physicians. I'm not saying we do cookbook medicine, but there is best practices out there. How do we know they even exist if we're sitting in a solo office in Pittsburgh? That's my hometown. So, you know, how do you know they even are out there? One of the things that EMRs allow you to do through health information exchanges and other methods is allows you to get those best practices start to be built into your office. And what you're going to see is those best practices are what they're going to measure when we get paid in the future. Also, patient safety. There's a lot of studies out there now that, especially in the e-prescribing world, medication errors, medication duplications, allergies have been greatly reduced in the e-prescribing world, simply because we check the things we should be checking. And it alerts us to the things we should be knowing. So I forgot this patient had a penicillin allergy, boom, it's right there in my face now. I can prevent that error from happening. Other parts of quality, timely, reduced wait times. I think EMRs over time and health technology over time is actually going to speed our practices along. It's going to provide us with information that we used to have to go back to our offices and look up on a real-time basis. And it's going to be patient-centric. So it's going to be able to look, as our EHR does, back in history and say, oh, in the past, this patient has had this particular diagnosis on these 5 dates. What was done for that particular time of their care? So the ability to start to make that efficiency roll through. Also, it has to be independent, and this is my political statement, independent of gender, ethnicity, region, or socioeconomics. We need to be treating patients regardless of their ability to pay, regardless of who they are or where they come from. If they're there in your office and they have a disease, that's part of quality. You got to focus on them regardless of their background. So let's talk a little bit about the future goals of healthcare IT. I talked about the fact that HIEs are going to happen, and they are. that information is going to start to flow coast to coast, and it will probably be really operational over the next 3 to 5 years. The evidence-based decision-making is going to be more and more as time goes on. And what I mean by that is we're going to be held accountable for quality measures as physicians. Those quality measures are actually based on two things. One is cost of the disease you're treating, because some of these are real high-cost diseases. Diabetes is one, asthma is another. The other is being able to follow those guidelines so we can actually demonstrate that quality and be paid for it. You know, safety is a priority in any type of exchange of information, as well as within an EMR as well as outside an EMR. And this quality has to be transparent. I talked about that. We are going to have report cards. I got to speak with the ONC 2 weeks ago, and it's going to be there. We're going to have all these things listed both at the state level as well as the federal level regarding our report cards as meaningful use data starts to roll in. So some of the other future goals, that information superhighway, patient-derived information. This is another thing that you're going to see. Within the product that we have at MED3000, we have a patient portal. Patients are allowed to enter their data directly into my health record. So now I get that data, and I can either approve it, pend it, ask the patient questions about it, but they're inputting it. So it's the best way to get information is asking the patient to do it directly, because it starts to minimize some of the error that can be put in. The data exchange standards, one of the things that is holding this whole process back is the fact that there's not been a lot of standards out there. They're starting to get their act together on the federal level to do that. We have better interfaces, better abilities to actually document on an EMR. If you'll stop by MED3000's booth, I'll show you what that really looks like. Templates both can be optimized as well as driven for quality purposes, and that clinical decision support can be kind of layered in there as an advantage. Now, some of the physician issues on my next to the last slide are real. There's a lot of folks out there sitting on a fence, and I just read a study yesterday that about 80% of physicians still have no plans to do meaningful use over the next 2 years. No plans. So there's about approximately 900,000 physicians, so 80% of them have no plans to do meaningful use. They're waiting because they don't feel this is of value enough for them to do. They really start to doubt the fact that EMRs actually can benefit their practice and benefit their patients. They're more seen as a hindrance than a help. I think that will change over the next several years as well. We have no willingness as physicians to change our habits. Why do you do something the same way you've always done it? Well, because it's kept me out of trouble. Drive a very discreet box. I treat my patients. They get better, seem to, and I'm fine with that. But we want to change the way we do things, and in the future we're going to have to. I ask this question a lot of physicians I talk to. Remember the CAT scanner? I graduated medical school in 1985. Remember that first CAT scanner, if anybody's a physician, and what that looked like in 1985? It's a totally different box today, and the pictures are stunning. You've seen these 3D images of infants in wombs, including all the facial recognition. I mean, it's just unbelievable. That wasn't there 20 years ago. So if you think what your EMRs look like today, think what they're going to look like in the next 10 to 15 years. Think about what that health information exchange is going to look like in the next 10 to 15 years. We're going to find more hospitals supporting this. A lot of physicians are headed to hospitals as a practice. We're going to have all of this available to us on our smartphones, our iPads, which you all have in front of you. And pretty soon, sooner or later, we're going to have this high-speed wireless access so we can get this anywhere, from our smartphone to our computer to wherever we need it. So we can sitting at a patient's bedside, we can sit in an office, we can sit wherever we like. Now, my last slide is a bit of history. So a lot of people wonder why in the world all this big push for healthcare IT. Well, as everyone recalls, there's the American Recovery and Reinvestment Act. And the reason the federal government did this is stated on this slide. They expect to save $60 billion in healthcare costs in our country over the next 9 years. They figured out that only about 65% of physicians would have done anything without an incentive. So with the incentive, they're hoping to boost that to 90. And if you look at a recent CMS study, they're actually headed in that direction. That growth curve of physician adoption is headed up the steep part of the curve now. So we're going to see a lot more people making that decision, even though approximately 80% now have not. So we're going to see over the next couple of years that's really going to take off. I think it's going to take off for a couple of reasons. Number one, that value proposition is going to be there for the patients and for the physicians, and it's going to, EMRs and technology are going to be seen as an adjunct to what we do in our offices and our practices as opposed to a hindrance. Thank you. That's my 15 minutes. I'll be happy to answer any questions.